So we have, as this session, the long-term follow-up, and then the following session will be short-term follow-up. So we have these slightly in reverse, so please bear that in mind when listening to this session. There will be more to come that fills in that gap. So I want to start really by just giving you a brief outline of my session. So really just thinking about the definitions, what is long-term follow-up care? When do patients reach that point in their journey? Why is it important? Why do we need it? Why should we care when patients are cured? What the risk factors are that influence the trajectory of the long-term follow-up. I'm going to describe a couple of screening schedules just to give some context around the investigations that are currently practiced according to the guidelines, and then just provide a brief example of the clinic that I set up and lead in my hospital at King's College Hospital in London. And then I'm going to just introduce you to a couple of the abstracts that were presented at EBMT this year that relate to long-term care. So a couple of definitions, sorry, a lot of words on the slide, but a long-term survivor is generally people who are reported to be alive and free of their disease at 2 years after transplant. They're called long-term or disease-free survivors. And survivorship itself is a rather nebulous concept. There are various definitions. People often get this wrong. It's not about being alive at a certain point, but it encompasses not just living past the milestones of day 100, 6 months, 1 year, 5 years, but also the expectations of a return to some physical and mental well-being and the continuation of the pursuit of a normal life or meaningful life. It recognises that each of our transplant recipients will have very different complications, different expectations depending on their context, and they'll also face different challenges and triumphs along the way. And I think we can all identify with that concept of survivorship when we think about our patients that are recovering and in that zone. So just thought I'd provide some numbers really to give you some context around some of the problems actually that we face with our survivor population. We've actually got quite good at looking after people post-transplant, so much so that the number of people that are living beyond those first few months and first few years is increasing, and that does pose a problem for us when considering service development and service growth for our survivors. So the number of transplants is increasing year on year. That's that top graph there. And then the bottom graph there from the 2019 data of CIBMTR shows the number of people in follow-up according to the years and ages. And you can see that is increasing. So the drivers for this are increased transplant numbers. Our reduced intensity conditioning regimes have meant that we can transplant more people safely. We get them through that first bit of the transplant phase, so we have a much better chance of being able to look after them in the longer term. Having access to a whole variety of cell sources, so effectively there's a donor for almost every single patient now, so managing to find a donor isn't really a limiting factor, so much so as it was maybe 10 or 20 years ago. And we're also gathering new indications for our patient population, so with autoimmune diseases and indications like sickle cell transplant coming nicely through to the adult setting. We also have better supportive care, so we're much better at looking after our patients, we're better at anticipating organ damage, our infections, and our severe graft versus host disease. So we know that the immediate survival after transplant's no longer enough. Our patients expect more from us, and that's correct and right. Our goals should now include a complete recovery of the health status, with as near normal as possible physical and psychological or psychosocial functioning, normal family and social integration, and good subjective well-being. So we want our patients to tell us that they feel well after the transplant, and this is not just about having a normal blood count or being free of leukemia or having controlled graft versus host disease. But we know that the mortality is 4.9 times higher than the age-matched peers in the general population. Our patients are 2 times more likely than their siblings to develop chronic conditions. They're 3.5 times more likely to develop severe life-threatening conditions, and that is 4.7 times more likely if they have chronic graft versus host disease. More than 95% of our long-term survivors report the need for medical contact, and the need for physical examination increases over time. So we need to continue to look after these people year on year, lifelong. And we know that actually there are a number of major risk factors for late effects, and really we should start planning for long-term care at the time of transplant or before transplant, when we start to accumulate and acquire knowledge about our patients as individuals through their pre-transplant workup, through our knowledge of them as individuals and as people with aspirations and hopes. So there are 5 major categories for late effects: patient factors, disease features, the conditioning regime that we select, and whether we can minimize and mitigate some of the toxicities of that. The graft source will also play a role in how our patients fare in the long term, and the presence or absence or severity of graft versus host disease. So this slide, I won't read it through, but we have some common late effects and their risk factors listed here. As you can see, there's a huge list, and the list of risk factors on the right-hand side really tells us that it's quite hard to avoid at least some toxicity associated with the transplant. And how those toxicities will play out in the longer term is very much down to our surveillance as practitioners and the other risk factors that our patient might bring to transplant with them, in addition to a whole host of unknown factors that we can't really account for in that pre-transplant setting. The effects of late effects are multisystemic. Not all of our patients develop late effects. I have some patients in my long-term follow-up clinic who are more than 25 years post-transplant, who are living normal lives without any toxicity at all and feeling very well, certainly from a physical perspective. But some patients will develop many, and there's a huge need for our ongoing surveillance to be individualized and personalized, because for all of our patients it's critical to be able to do that and make those facilities to limit our late morbidity and mortality. So I don't expect you to really be able to see this in any huge detail, but this is a schema that's based on the MAGEL guidelines from 2012, and if you look around on kind of CIBMTR and EBMT websites, these are the guidelines that are pretty much still dictating how we run our long-term surveillance, our late effects clinics. But obviously they're getting pretty outdated now. They're 10 years old or more, certainly published in 2012, and we're now obviously in 2022. I understand that the next iteration of these is perhaps 3 to 6 months away from publication, so we eagerly anticipate those because that will have an impact on some of the surveillance that we're currently doing I understand that some of the investigations will be recommended to be undertaken a bit more frequently, and there'll be additional investigations as well. Things like metabolic syndrome, we understand a lot more of that about that now and its major role in long-term trajectory than we did probably 10 years ago. And I think that serves as a really good example for how we need to see some more updated guidelines. But this essentially gives some guidance on the frequency of testing that needs to be undertaken 6 months, 1 year, 10 years, and the testing that we should be doing annually. So, for example, it's not necessarily critical to undertake bone densitometry every year if the patient's bone densitometry is normal when it's checked and they haven't acquired any new risk factors for poor bone health, then you don't need to keep exposing your patients to further densitometry. Things will crop up potentially during their lifetime that might encourage you to order additional investigations, but it's not necessary otherwise. So this is just an outline of the way that we run our long-term follow-up clinic at King's College Hospital in London. Referral criteria, our patient needs to be in remission. They can have graft-versus-host disease, but it's generally stable or absent completely, and no ongoing disease treatment, aside from TKIs. They're referred in at 12 months, and then they're seen annually in the long-term clinic thereafter for the rest of their lives. The minimum frequency of reviews in the first 1 to 5 years will be biannual, so they'll have an annual review in the long-term follow-up clinic with other reviews in our general post-transplant follow-up clinic. So they'll be seen at least twice a year. And in the long-term follow-up clinic, we're implementing the screening guidance, again, based on the MAGEL guidelines. I'll show a slide of our screening report in a moment. We also undertake holistic assessment, so all of our patients are encouraged and invited to complete a holistic assessment. It's a multi-domain assessment, very much like quality of life, where they self-report any psychosocial issues that they're experiencing, and then we're able to address those in the context of the long-term follow-up clinic, and they complete that online through a hyperlink before their appointment, so we can walk them through that when we see them, either in person or the way we have been the last 2 years is over a telephone or video consultation. We offer a lot of patient information and signposting as a result of the sort of consultation conversation and also as a result of the holistic assessment. And we play a huge role in helping to modify the health behaviours of our patients in this clinic, either in response to some of the blood parameters and values that we see, or through the conversation, or based on baseline values like their blood pressure or their weight. And at this time, we make any additional specialty referrals, maybe to menopause clinic or erectile dysfunction for our patients, or to psychotherapy, et cetera, and also all of the other specialists like dermatology, cardiology, respiratory, if we're finding anything at these time points. And we also start to increase the primary care support. So, as we all know, primary care physicians are often not involved. We keep them at arm's length for quite a while, certainly before and after the transplant, but it's really important that patients are able to access care for their basic needs closer to home. And so primary care does have a very important role in being able to deliver this. At 5 years, if all is well, then they're discharged from the routine post-transplant follow-up clinic and they're just followed in the long-term clinic alone. And that's just an annual review. And at that point, we're sort of kind of really phasing in patient empowerment strategies. So really encouraging our patients and equipping them with the tools to be able to advocate for themselves, to be able to articulate to primary care when they have a small problem, to know when to get in touch with us in between their annual reviews, because of course, things happen in the meantime, and we don't want our patients to save all their problems up just for the annual review. It may be necessary to fast-track the patients back into our regular post-transplant clinic for any interim care or consultations that they might need. And then the rest of the care is pretty much the same year on year. This is our clinic report. I'm not sure how clear that comes up, but now there's a pointer on here, I think. I can't work it, but it doesn't really matter. So we do vital signs, observations, full blood count, all of the other kind of blood parameters as per the guidance. You can see there normal pulmonary function testing done in 2017. This is a patient who is 18 years out post-transplant, no new respiratory signs. We don't do another lung function. We have this corner of lifestyle kind of validation questions, essentially. So if the patients haven't really articulated anything on the holistic needs assessment, then this is our opportunity to kind of ask them outright, how things are going with their weight, and have a kind of weight management conversation with patients. If having an exercise conversation, talking to them directly about sexual function, and often our patients will find it quite difficult to talk about sexual function. Of course, that's a whole other talk. That's not the one I'm here to do this morning, but it's quite important that we have an opportunity to ask our patients, so that as we often feel uncomfortable as clinicians, our patients will often feel uncomfortable talking about it. So validating that, giving that problem issue airtime. We also talk to our patients about alcohol and smoking and use this as an opportunity to have a brief kind of targeted conversation about some of those lifestyle issues. For the medication, it's also important to ensure that what the patients are prescribed, they are actually taking. And again, sometimes primary care physicians will adjust dosages of some of the medications, so we put these back on track when we see the patients in the clinic. Having a problem forwarding the slide. There we go. So these are just a couple of abstracts from the 2022 meeting. So this is quite interesting. It's a kind of patient-reported and proxy-reported outcomes among some pediatric allogeneic transplant recipients for non-malignant disease. And the title that they use, the strap, is "What doesn't kill you makes you stronger." So it's a single-centre cohort study looking at patient-reported outcomes, which were evaluated between December 20 and March 2021. Patients are more than 2 years after a paediatric allo for non-malignant disease, and they used age-appropriated patient-reported outcome measures. Patients that were more than 8 years completed their own, and less than 8 years, they were completed by proxy, so usually a parent. And they use validated tools to do this, and then, as you can see, the analysis. So the results are quite interesting. They had 119 patients participated, which is a reasonable number actually for self-reports, with a median age of 15.8 years, and about half of the patients, more than half of the patients were male. You can see a fairly even disease split across inborn errors, hemoglobinopathies and bone marrow failures. And you can see, again, a sort of a bias towards triasulfan and busulfan, with cyclophosphamide-based regimes taking up the smallest proportion. There were significant lower scores in the patient-reported outcomes compared to Dutch population, and physical health for children between 5 and 7 years in adolescents, and also reductions in psychosocial health for adolescents and school functioning for children aged 5 to 12 and also adolescents. But the young adults, the 18 to 30 years, reported no significantly different scores, which is quite interesting. So their conclusions were a normalisation of long-term reported outcomes in patients after paediatric transplant for non-malignant diseases in many of the domains, but more attention was needed for physical health, school and cognitive functioning, and that children and adolescents seem to be the most vulnerable, indicating the need for early supportive care to prevent long-term impaired quality of life. My second abstract is on a randomized trial of the impact of virtual-based multimodal training program on physical fitness and quality of life in patients late post-transplant. And this abstract from Australia was really looking at the impact of exercise on reduced quality of life in transplant survivors. And so they wanted to look at physical training and psychotherapy intervention, and using an audio-visual platform to do that. So their study just reported the 3-month outcomes following a multi-centre randomised control trial of virtually supervised combined modal training. So I've put in an algorithm here just to show the randomisation. So patients were consented in an in-person introductory session to either the control group or the intervention group. Control group were instructed to maintain their usual activities, and the intervention group received instructions plus a weekly physical training and mindfulness-based stress management for 6 weeks via a video consultation. The assessments for both groups were done pre-training at 6 weeks and 3 months, with a primary endpoint looking at the 6-minute walk test and some other secondary physical, quality of life and psychological measures. So you can see the eligibility include people that were more than 18 and more than 6 months after transplant, and they had to have basic computer skills to be able to utilise the platform. They didn't include people with severe graft-versus-host disease who arguably might have benefited from this intervention, and they didn't include people with understandably exercise-limiting cardiovascular disease and severe anxiety or depression. Patients attending 4 of their clinics were invited, and consent was done in person. So they had 139 of 219 responders who participated, and it was a one-to-one randomization with patients actually a median of 21 months post-transplant. So a fair way out, almost 2 years. Median age is 58. And 25% of those patients lived more than 50 kilometres from the transplant centre, which would really have mitigated them from or excluded them from an in-person intervention. No real significant differences in the intervention and control groups concerning the variables mentioned there. So when you look at the consented participants of 139, the number that completed all of the assessments through the whole trajectory at pre and 6 weeks and 3 months, in the control group 128 and 130 in the intervention group. In the control group, the physical therapy and mindfulness-based stress management logins remain static, and the 6-minute walk test improved from 464 to 501. However, for the intervention group, the logs for physical therapy and MBSM increased over time, and the 6-minute walk test increased from 463 to 549. The intervention group favoured in 30-minute stress test and DAS depression and HADS anxiety as well, strength test, sorry. So for their conclusions, their 6-week virtually supervised intervention group improved with their physical fitness and their strength with the 6-minute walk test and strength testing, and also for their mental health for anxiety and depression. Interestingly, improvements in the 6-minute walk test and strength test correlate with increased functional capacity, and an over 50-meter increase with the 6-minute walk test is shown to correlate significantly with functional capacity and health outcomes. So the intervention group had a significant improvement. So they concluded that the virtual-based training program demonstrated benefit to transplant survivors in their own homes. I think it's a fantastic piece of work that they conducted there. And so with this, I just want to thank you for your time and for listening to this presentation. We have our Transplant Complications Working Party for anybody who's interested in late effects and long-term follow-up, and that is happening in September 2022 in Berlin. And we also have our transplant EBMT textbook for nurses with the hyperlinks there for both of those resources. Thank you.